Welcome all. So next talk article for discussion is acute and chronic pancreatitis in pregnancy. This talk article is also very important because one or two SBS come from this talk article. So incidence of acute or mainly acute pancreatitis is around 3 per 10,000 pregnancies. Maternal mortality is reduced now. It is 3%. Initially it was 37%. Okay. Fetal loss is around 3%. And this is mainly it is increase in patients who have the hypertriglyceridemia. Increased risk of pancreatitis is in late pregnancy and the postpartum. Again, here is a SBA regarding the etiology of the pancreatitis. Okay, the most common etiology is the gallstone. More than 65% of cases, it is the gallstone uh, and associated with increased parity. The hormonal under the hormonal influence, there is a biliary sludge, and gallstone is the most common cause in more than 65% of cases. Alcohol is seen in 5 to 10% of cases, less common in pregnancy than the general population. Hypertriglyceridemia is seen in around 4 to 6% of cases, especially in third trimester. Triglyceride levels are increased 3 times. Idiopathic is the diagnosis of exclusion. Here, the etiology they can ask you in SBA. This is a recall question. Then rare causes like drugs, hyperemesis gravidarum, acute fatty liver of pregnancy, hyperparathyroidism, HELP syndrome, and genetic mutations. These are rare causes. Okay. So clinically, patient will have a typical sudden epigastric pain, which is related to the back, nausea, vomiting, anorexia, epigastric tenderness, fever, tachycardia, and decreased bowel sounds. Okay. So if the patient has got a fever, it is mainly because of the systemic inflammatory response. Okay, and this is not because of the infection. Okay, so differential diagnosis to be kept in mind. One is hyperemesis gravidarum, preeclampsia, HELP syndrome, placental abruption, and other non-obstetric causes such as biliary colic, gastritis, peptic disease, etc. Okay, so diagnosis requires at least 2 of 3 criteria. That is, one is a typical abdominal pain, which I have just described. Then amylase and lipase levels are 3 times of the normal, and generally they are more than 300 units per liter, and imaging features suggestive of pancreatitis. Okay, so what imaging modality is preferred, we will discuss now. So imaging strategy, the preferred and the first line is the ultrasound, okay, abdominal ultrasound. That is the first line, and it is likely to show the gallstone, though sensitivity is less. Second, MRI without gadolinium. It is safe in the second line. CT scan if needed, and that is not contraindicated. So if required, we can do CT also. But key point you have to remember that CT and MRI is to be delayed at least for first 5 days. Okay, so you can do it on day 5 or after day 5 because it takes time for the necrosis to happen. Okay, so CT and MRI is mainly required to look for this pancreatic tissue necrosis, and it takes time for this tissue necrosis to develop. So this CT or MRI is to be delayed by 5 days. This is the thing which is given in the talk article. Okay, ideally this should be done after waiting until at least 5 days from the onset of pain, because it takes several days for hypoperfusion necrosis to emerge. Ultrasound is the first choice for imaging the pancreas and gallbladder during the pregnancy, but it is not sensitive enough to detect the bile duct stones in most patients. So further imaging may be required. MRI without gadolinium contrast is considered safe in pregnancy, and abdominal CT scan exposes the fetus to the radiation in a dose of 1.3 to 35 milligray with levels less than 50 milligray considered acceptable in pregnancy. Okay, so therefore, if CT is clinically indicated, then pregnancy should not be considered a contraindication. So you can do CT also, MRI also, but the first line is a ultrasonography. Okay, and what is the time, that also please remember. Okay, then they may give you the long scenario. They may ask the further investigation which is required, and it may be either MRI or the CT. Okay, and the MRI without gadolinium. Severity classification, it may be mild, moderate, or severe. In mild cases, there is no organ failure. Moderate, there is a transient organ failure and it resolves within 48 hours. While in severe, there is a persistent organ failure and more than 48 hours. And these are the cases which are likely to land up with the pancreatic tissue necrosis. Okay, so score of 3 or more is considered as a severe pancreatitis. Okay, so there is a modified Glasgow score, and the score of more than or equal to 3 will be severe pancreatitis risk. Okay. So the mnemonic for this score is a pancreas. So what are the parameters? Pancreas, pancreas. Okay. PaO2, age, neutrophils, calcium, renal, enzyme, albumin, and sugar. So this is mainly used by the surgery people. However, pregnancy it is not very specific. Okay. So PaO2 less than 8 kPa, age more than 55, neutrophils more than 15,000, calcium less than 2, uh, urea more than 16, in LDH more than 600, albumin less than 32, and sugar more than 10 millimoles. However, pregnancy definitely alters the WBC values and the albumin values, because albumin is reduced and WBC increased in pregnancy. So this will alter the score. Okay, so not very specific. Okay, so this score is not validated in the pregnancy. So CRP level more than 150 milligram per liter on day 3, that is suggestive of pancreatic necrosis. Okay, so this also you should remember when there is deterioration, because in moderate cases there will be organ failure, but there will be resolution within 48 hours. But if the CRP is more than 150 milligram at day 3, that is pointing towards the deterioration leading to pancreatic necrosis. Okay, so pancreatitis is it may be interstitial edematous pancreatitis, that is mild, and second is a necrotizing pancreatitis, which is severe. Okay, so there is inflammation without necrosis. General resolution is within 1 week, and most common type is the interstitial edematous. While pancreatic necrotizing pancreatitis, where there is a pancreatic and peripancreatic necrosis seen in 5 to 10% of cases, the course is prolonged and variable, and there is increased morbidity, and interventions are required. Okay, so at diagnosis, always we have to take a detailed history of alcohol, look for lipid profile, IgG4 in autoimmune disorders, and get the ultrasound done to look for the stones, gallstones, I mean to say. Then coming to the chronic pancreatitis in pregnancy. Chronic pancreatitis is not very common in pregnancy. Usual age is around 36 to 55 years. Generally seen in male. Okay, hence uncommon in obstetrics. Okay, so key problems in pregnancy. When we deal with this pancreatitis, or especially chronic pancreatitis, it is a pain which is difficult to manage. Patient requires lots of painkiller, and we have restrictions regarding use of painkillers. Okay, then exocrine insufficiency will lead to malabsorption and diabetes mellitus. This mainly because of the endocrine insufficiency. There is a maternal and fetal risk. So these are the problems in patients with chronic pancreatitis. So management principle, you have to do the nutritional assessment, pancreatic enzyme supplements, pain control, monitor for diabetes, and multidisciplinary team care. So most common cause of in pregnancy is the gallstone. Diagnosis requires 2 out of 3 criteria. Amylase lipase level is more than 3 times. Imaging first line is ultrasound. CT is not contraindicated. The severity scoring is modified Glasgow. Then CRP more than 150 will point towards necrosis predictor. Early fever is because of the SIRS, that is systemic inflammatory response syndrome, and not because of the infection. There is increased risk in the 3rd trimester and the postpartum. Then chronic pancreatitis, think of malabsorption and the diabetes. Coming to the management of acute pancreatitis in pregnancy, the principle is that this condition requires supportive and multidisciplinary care, similar to non-pregnant patients, and we have to give the fetal considerations also. So IV fluids, analgesia, VTE prophylaxis, nutrition, and critical care monitoring, antibiotics, imaging. So these are the cornerstones. IV fluids around 150 to 300 ml per liter. You have to correct the 3rd space loss. Maintain urine output more than 0.5 kg, 0.5 ml per kg per hour. There is increased 3rd space loss. So if there is an increased hematocrits, that will lead to the dehydration. And this is mainly because of the 3rd space loss. Okay, analgesia, safe is a paracetamol, but the patient may require opioid because of the severity of the pain. So severe pain will require opioids. VTE prophylaxis is given with the help of LMWH as per the RCOG guideline. Then nutrition, enteral nutrition, oral, nasogastric or nasojejunal tube. As far as possible, avoid TPN is not required. Then critical care, if there is organ failure, the patient will require ICU referral. Antibiotics only if there is an infection which is proven. not for SIRS. Okay. Then imaging, if the patient is not improving, to be delayed till 5 days. Okay. Then treat complication and hepatobiliary inputs will be required. And to prevent the recurrence, treat the cause, that is the cholecystectomy. Okay. Then fluid target urine output should be more than or equal to 0.5 ml per kg per hour. Feeding enteral is preferred than the parenteral. Antibiotics not routinely required. If there is early fever, it will suggestive of SIRS and not the infection. ICU is required if there are features of organ failure or severe disease. Then coming to the treatment of the cause, underlying cause. Okay. If it is pancreatitis due to the gallstone, which is the commonest cause, the laparoscopic cholecystectomy is advised. The laparoscopic cholecystectomy can be done at any trimester. Okay. Index admission, it can be done or within 2 weeks. Traditionally, it was done between 12 to 24 weeks, but newer evidence says that at any trimester it is safe. Okay. So it can be done on the index admission also. It can be done within 2 weeks also. Traditionally, 12 to 24 weeks was the period which was mentioned. However, as per the latest evidence, anytime trimester is safe. So unlikely this will be an SBA. Okay. Another intervention is ERCP. ERCP can be done in pregnancy. Use minimal fluoroscopy, and indications will be obstructive jaundice, cholangitis, persistent biliary obstruction. Then hypertriglyceridemia. The patient will needs to be kept kneel by mouth. That will reduce the triglyceride level. Insulin infusion by sliding scale and endocrinology referral is required. Then coming to the complications, local such as fluid collection, pseudocyst formation, necrosis, regional like gastric outlet obstruction, portal vein thrombosis, and systemic such as organ failure worsening comorbidities. So when to suspect complication? If there is a persistent recurrent pain, sepsis signs, organ dysfunction. So imaging by CT scan or MRI is required. Refer the patient to hepatobiliary or surgical team. Consider transfer to tertiary care. Coming to the pregnancy outcome and the pancreatitis. Preterm birth incidence is around 15 to 32%. Fetal morbidity is around 3 to 5%. Delivery decision, vaginal delivery is indicated. So cesarean section is only for obstetric indications. So clinical deterioration after 24 to 48 hours or moderate severe, then only go for a delivery. Okay, otherwise conservative management. Mode of delivery, vaginal delivery, and not vaginal delivery is not contraindicated. Decide based on the obstetric factors. Then antenatal interventions such as steroids will be required, magnesium sulfate, okay, for neuroprotection. Chronic pancreatitis, we have already discussed, is just a progressive inflammation, irreversible damage. Alcohol and the recurrent acute pancreatitis are the causes. And these patients will have exocrine insufficiency, which will lead to the steatorrhea, diarrhea, weight loss, bloating, postprandial pain. Okay. And management also we have discussed pancreatic enzyme replacement, nutritional support, vitamins, etc. is required. When there is an endocrine dysfunction, there will be pancreatogenic diabetes, and this is mainly because of the decreased insulin production and increased resistance. So glucose levels are labile. So these patients require OGTT at booking. So if there is a pancreatogenic diabetes, OGTT at booking is required. So early diabetes team input will be required. Insulin is often required for these patients and monitor nutrition for because of the malabsorption risk. For pain, the pain may be chronic and severe. Analgesia, go for stepwise approach. Opioids are often required. Among the opioid, tramadol is the preferred. Okay, so in chronic pancreatitis, tramadol is the preferred drug. Avoid pregabalin, okay, because it has got a teratogenic risk. So additional points to remember are pain worsens with eating. So intake is decreased and that leads to malnutrition. So use multi-dimensional painkillers. Then lifestyle measures are important. Ask to avoid the alcohol that will improve the pain, and advise to stop the smoking. Okay. So labor and neonatal considerations, opioid use. Because of the opioid, there is increased tolerance. So there is a requirement of the adjustment of the labor analgesia dose. And for neonates, we need to monitor for withdrawal. Okay. So this we have seen most common is gallstones. Management is supportive. Fluid is around 150 to 300 ml per hour. Feeding is enteral. Antibiotics only if infection. Surgery, cholecystectomy can be done. The delivery only indicated if there is a deterioration. chronic pancreatitis, malabsorption, diabetes, and chronic pain. These are the things which are important from chronic pancreatitis point of view. Okay, so that finishes this talk article. Doctor, we have few questions. Can you please go ahead?
Yes, sir. A 28-year-old woman at 30 weeks gestation presents with severe epigastric pain, radiating to back. She has temperature of 38.2 degrees centigrade, WBC 15,000. Serum amylase is elevated 4 times normal. No focus of infection is identified. What is the most appropriate next step? A. Start broad spectrum antibiotics. B. Urgent CT scan. C. Supportive management without antibiotics. D. Immediate delivery. E. ERCP. C. Supportive management without antibiotics.
Correct. Because up to 48 hours it is SIRS. Okay, so early pancreatitis will lead to SIRS. It is a sterile inflammation. Fever plus leukocytosis is not indicative of infection in these cases. So antibiotics only if there is a proven infection. So SIRS versus sepsis, that is what they want to check. Next.
A pregnant woman is suspected to have acute pancreatitis. Which combination confirms the diagnosis? A. Abdominal pain with the raised CRP. B. Raised amylase and ultrasound findings. C. Abdominal pain with amylase 3 times the normal. D. Abdominal pain with fever. E. CT findings alone. C. Abdominal pain with amylase 3 times the normal.
Yes, at least two findings should be there, and amylase level more than 3 times. Okay, diagnosis requires two out of three criteria: pain, enzyme increase, and imaging. Okay, next.
A 32-year-old pregnant woman with pancreatitis is not improving after 24 hours. You suspect necrotizing pancreatitis. What is the best time to perform CT scan? Immediately, within 24 hours, after 48 hours, after 5 days, after delivery. D. After 5 days.
Correct, because that is the time when the necrosis will appear. So necrosis takes time to develop. Early CT will give false negative. Okay, next.
A pregnant woman with pancreatitis has WBC 16,000, albumin 26 gram per day, glucose normal. Modified glycose score suggests severe disease. What is the best interpretation? A. Confirm severe pancreatitis. B. Ignore score completely. C. Score may be falsely elevated due to pregnancy. D. Start antibiotics. E. Immediate delivery. C. Score may be falsely elevated due to pregnancy.
Yes, because there,
There will
there can be decrease in the
increasing
albumin level and increase in
albumin,
the,
increasing
yeah.
WBC count.
The score may be falsely elevated due to pregnancy. Pregnancy, there is increase in WBC, decrease in albumin, scoring system not validated.
A
Next.
pregnant patient with acute pancreatitis has poor oral intake. What is the preferred nutritional strategy? Total parenteral nutrition, enteral feeding via NG, NJ2, keep milk by mouth for 7 days, IV glucose only, immediate surgery. B. Enteral feeding via NG, NJ2.
Yeah. Nasogastric or nasogenital tube enteral feeding via that is preferred than the parenteral. TPN only if enteral is not possible. Okay. Next.
34-week pregnant woman has severe acute pancreatitis. After 24 to 48 hours of optimal treatment, she deteriorates clinically. What is the most appropriate next step? Continue conservative management, immediate C-section in all cases, consider delivery based on maternal condition, avoid delivery at all costs, start antibiotics. C, consider delivery based on maternal condition.
Yes, because 24 to 48 hours treatment is already been given, so she will require. So delivery is not routine, indicated if there is a deterioration despite treatment and severe disease. Okay, so that finishes our talk on pancreatitis in pregnancy. Thank you, Dr.